Good morning, everybody. This is Dr. James Flowers. Welcome to Understanding the Human Condition. I'm here today with my good friend and colleague, Dr. Jon Stevens. Welcome.
Thank you, Dr. Flowers. Nice to be here.
I'm so glad that you're here. Your schedule is packed every single day, and I'm honored that you were able to take an hour or two out of your day to come over here and visit and do this podcast with
Oh,
me.
I love coming over here. Great people, beautiful place you have.
I
So,
love it. Thank you so much. It's good to see you in person. We talk on the phone, but we don't get to see each other
right.
every day because of our schedules. But today, what you and I decided that we would talk about, I think, is something really important, and it's overall general health. But Dr. Stevens, you're a psychiatrist,
Right.
and we're going to talk, you're a child and adolescent
Yep.
psychiatrist, and one of your many board certifications, I should say. But today, we're going to talk about something that most people don't really think a psychiatrist, oh, I'm going to talk to my psychiatrist about medical weight loss, right? So today we're going to talk about medical weight loss and what that means. We're going to talk about some statistics. We're going to talk about some medication of choice and some lifestyle implications. So first of all, Dr. Stevens, why go to a psychiatrist and talk about medical weight loss? Talk about that.
Yeah, well, wasn't something that I started my
Yeah.
career and thought I'd be really interested in. And I have a confession for your audience is for many years, I was part of the problem.
Mhm.
I was the culprit. And
Okay.
what I mean by that, before you call 911,
Exactly.
is I'd be working with populations, especially sicker populations on an inpatient basis, whether kids, adolescents, adults, and many of the medicines that I was using were putting on weight for people, dangerous amounts of weight, sometimes slowly in an insidious fashion, a couple pounds a month.
Mhm.
And when I trained and moved to an outpatient setting, those 2 or 3 or 4 pounds a month over years of caring for people added up to significant and dangerous weight gain. So part of getting board certified in obesity medicine, really doing that journey during COVID and
Mhm.
having the time to kind
Yeah.
of focus on that, especially was really scratching my own itch. It was because my patients were gaining weight, were developing complications of obesity, and we needed to find together interventions that would help them.
And on the therapeutic side at J Flowers, we see patients every single day that when we talk about an appointment, whether it's with Dr. Stevens or another psychiatrist, they're like, oh my gosh, please don't put me on medication that I'm going to gain weight.
Yeah.
It's their number one complaint that we hear day in and day out from patients about medication resistance. It's, I don't want to gain weight. I've tried this in the past and I gained 20, 30, 40 pounds over the years. And then they say once they gain that weight, it's harder to lose than it was prior to even being on medication. You heard that?
That's absolutely the case. The
Yeah.
body has multiple compensatory mechanisms that when you're starting to gain weight, there are a lot of factors that
Hmm.
are pushing back, metabolic factors
Right.
that are pushing back in the body that prevent you from going back to your original weight. And part of that is driven by evolutionary mechanisms.
Hmm.
You don't want, the body doesn't want, biggest danger for most of human existence was
Hmm.
starvation.
Right. Yeah.
So we are in now this really time of plenty, but too much so. And that
Sure.
without, really being careful about what we consume and how we're exercising in terms
Hmm.
of how we're increasing movement, we're really at risk. There have been some studies, including one in the New England Journal of Medicine, that said in the next 10 or 15 years, practically everyone in America could be overweight or obese.
That is just
And we're
wild.
already at
Yeah.
60% when you count overweight and obese.
Right.
40% of Americans are clinically obese. I'm not using that term in the pejorative sense
Hmm.
that it's oftentimes used. So
Right.
this is really a crisis and epidemic that we're facing.
It is. I mean, no matter what part of the country that we're in, whether we're in California, Texas, New England, Southeast, Southwest, Northeast, Northwest, we see in the United States in general, we're seeing a much greater level of obesity than we've ever seen before. What do you think brings that on?
Well, I think it's America has done it the best.
Yeah.
We are the most overweight and obese country on the
Mhm.
planet. I think that obviously the material wealth and the
Mhm.
nutritional wealth
Mhm.
has created some of that, as well as just technological changes. We are not working the farm anymore in terms
R-
of exercise.
Exactly.
And with many of our
Yeah.
jobs, whether we talk about, especially since
Mhm.
COVID, is
Right.
sitting at home working at your desk or
Yeah.
your chair
Mhm.
and just not getting really, there's a imbalance
Mhm.
in energy consumed in terms of the form of calories
Right.
and energy burned.
Yeah.
And if that imbalance persists for a while,
Right.
the weight will add on. It's mathematical.
Yeah.
There is a small percentage, probably about 5 people, especially that for those that suffer childhood obesity, that
Mhm.
do have genetic factors, that do have underlying
Sure.
inherited either
Mhm.
mutations in the melanocortin 4 receptor
Mhm.
or other genes that are linked to that. For the majority of people, the weight gain that contribute to overweight and obesity is environmental.
Yeah. And speaking of COVID, and
Yeah.
so the other thing that we hear a lot of is, oh my gosh, during COVID, I was immediately sent home and I worked from home and I sat at my desk all day and I gained 30 pounds over the
Yeah.
2 years or year and a half, 2 years that COVID was keeping so many people at home. And people haven't been able to get off of that roller coaster weight going kind of up and down and getting back into a normal routine exercise. But what I want to talk about first is let's talk about statistics,
Mhm.
right? Some World Health Organization statistics.
Yeah, it's not just an American problem. Obviously, we're talking predominantly American audience,
Yeah.
hopefully outside, but the worldwide prevalence of obesity has doubled since 1980.
Wow.
So it is not just an American problem, but again, the way we eat is also being adopted and sometimes glamorized. I
Mhm.
mean, throughout the world with fast food,
Right.
with sugary drinks,
Mhm.
with high salt snack, these, high fat and very processed and ultra processed food. I think that that is also partly to blame. Then over that time, just the rise of technology. You and I see a lot
Sure.
of adolescents coming either J Flowers in our private practice, but when you're on the phone, you're not on the basketball team, and
That's
there's just
right.
only so many hours
Yep.
just, glued to technology
Yep.
that inherently is a sedentary activity. I don't know
Absolutely.
if that
And even in adolescence, we're
yeah,
seeing, back when you and I were children, our parents said, "See you at 5 o'clock," or "See you tonight, be home
go
by
play.
7, go
Go
play,
outside and play,
go
lock the
outside
door.
and play." And nowadays, teens and adolescents are just going upstairs or in the den and they're turning on their TV and getting their game out and literally sitting on the sofa for 3 and 4 hours at a time
Right.
and not getting any exercise out of after.
The rates of childhood overweight and obesity are increasing even faster than adults,
Yeah.
which is terrifying. And because as we said, once the body gets to that space, the body sets at that space. So there's a lot of compensatory mechanisms that's pushed
Mhm.
back. Again, a dirty secret is that diet and exercise, once you're already in a clinically
Mhm.
obese realm, only really lead to about 5% body mass loss. So
Right.
if you're let's say 240 pounds as an
Mhm.
adolescent, which is not unusual, Dr. Flowers. That is not. So if you're
Yeah.
talking about, I'm telling you, okay, if you completely change your lifestyle, get 150 minutes of movement that gets your heart rate up
Mhm.
every week, that's 150 minutes,
Okay.
and you cut out all the processed foods, all of the fast,
Yeah.
no more soda, you could lose at 240, you could lose 12 pounds.
It's amazing.
That's not going to be
That's not gonna
inherently
be.
that. I mean,
Yeah.
would you do that
Yeah.
to lose 5%?
No.
You'd
Right.
say they were gonna say, "I need to lose 40 or
Right.
50." So that's
Absolutely.
why we really need new kinds of interventions.
Yeah.
And most of the people I see, honestly, have done all of these things,
Yeah.
have done,
Oh my
all sorts
gosh.
of weight
Yeah.
loss, diets, everything. They'll tell me stories, and half the time I have to look them up because I'm like, "I
Right.
never heard of that."
Absolutely. Yeah.
Like, "You really did the cabbage soup diet? I didn't think that was real.
Look
I
at
thought that
that.
was kind of
The
like a
lemon
joke."
water, the honey,
Oh,
all
you
of that.
okay, there you go.
Yeah.
Yeah.
I want to talk about also gastric bypass surgery and lap band surgery. I have done over the years of practice, I have done probably greater than 3,000 weight loss pre-surgical psychological
Mm,
evaluation. And they would look for clearance. The surgeon would say, "Can you clear this patient for surgery to make sure they can follow our instruction?" We would have people that would come in for a behavioral evaluation who were looking to lose 125, 150 pounds and say, "I can't live anymore with like this. I've got to do this." But through the testing, we found they were not going to be able to follow a new diet and a new restriction. A lot of times the surgeon would do it anyway, and those patients' lives were miserable, miserably affected because it changes everything in our right
right.
overnight when you have that surgery. But what I want to go back to real quick is during COVID, you decided to get boarded in, is it weight
Obesity medicine.
obesity
Yeah.
medicine?
Yeah.
Yeah. Talk about what did you do to get boarded in obesity medicine?
Well, it was something that I like again, I had been using oral agents like
Mhm.
metformin
Yep.
with patients on antipsychotic or mood
Right.
stabilizing medicines probably for years
Mhm.
before that. They're not FDA approved for that.
Yep.
And then many of the medicines that are approved for oral medicines are psychiatric medicines
Right.
like Wellbutrin or
Mhm.
naltrexone or topiramate, Topamax. So I was already familiar. I was watching this field, but some of the trainings required weeks in different parts of the country. And I
Yep.
have three small children. So the idea of going to New York City for
Yeah.
weeks and undergoing conferences and doing all the work was
Right.
really, really daunting. So for
Yeah.
many years, I put it off. But then with COVID, a lot of these things went online
Virtual.
and I
Yeah.
was able to do it in odd hours and
Yeah.
looking, watching, studying, doing all the things that it took to
Right.
get board certified. And then telling my patients about it, I wasn't sure how they would respond. Again, it didn't feel most people that are in obesity medicine are internal medicine doctors,
Mhm.
family medicine,
Right.
so endocrinologists. So I felt like a little bit of an odd, but I think the response has been fantastic and people really like the conversation. I started earlier now when you talk about those patients. I know we
Yeah.
see these patients that are
Mhm.
saying, I will not go on that medicine if I gain weight. It's very reassuring to say, don't worry, I am totally sensitive to
Yeah.
that. Let's think of a strategy.
Yeah.
And even if you did, we can find ways to take it off.
Yeah.
Because really the mental health is the primary
Sure.
concern for these issues. If you're manic or colossally depressed or psychotic, the
Uh,
weight loss has to be secondary.
Absolutely. You know, it's so interesting. Again, I'll tell you, talking about the reception of what you're doing and, old school psychiatry probably never would have thought about, oh, well, yes, they're gaining weight, but that's not my issue. And I
Right.
think it's amazing that now psychiatry is looking at it saying, I see that my patients are gaining weight and I
Yeah.
hear their complaints of it. And now I'm boarded in something that now I can do something to help about it. Right.
When I
Medically appropriate.
Yeah, even when I was doing the training, I
Yeah.
submitted the reimbursement. Doctors, when you do that, and you're
Yeah.
working. I worked at a local
Yeah.
hospital institution,
Yep.
and I submitted the reimbursements for some of the training. And the hospital administrators were like, "What? What are you doing?"
Yeah.
It was put off. They didn't pay it for months. I think they eventually did, and
Yeah.
I'm
Right.
thankful for that. But
Yeah.
they put it off, and even other
Yeah.
doctors were like, "What are you doing this for? How is this
Mhm.
going to help our patients?" Because we wouldn't talk about it, and a lot of doctors don't talk about the long-term risks.
Right.
Patients will say, "What are the side effects of this medicine?" And they might say, "You might be sleepier, you might have
Mhm.
constipation, you might have da da
Right.
da da," but they don't say because we know
Yeah,
if you could potentially gain a
that's right.
dangerous amount of weight
Right.
or
And that's one of
clinically
the things
significant
left
weight.
out of, oh, and you can gain 20 or 30
Right.
pounds.
And especially, if you're in a
Yeah.
hospital for a week,
Yeah.
the doctors are moving very
Mhm.
quickly. They're not thinking about, they're trying to
Right.
get you stabilized, that
Mhm.
you're not suicidal, you're not
Right.
homicidal
Yeah.
to get out of the hospital. But the
Yeah.
long-term complications in the office are staggering. I'm talking about risks of cardiovascular disease, risks of stroke, risks of joint disease, the
Mhm.
pressure that's put on joints. A lot of people, their joints wear out. And you talked about gastric bypass
Right.
surgery, but a knee replacement's not exactly an easy thing to
It's
recover
not.
from.
That's right.
And then even increased risk of cancer. So I've had patients that, unfortunately, in my practice over the years,
Mhm.
died many years too early from the complications of obesity because we weren't targeting that as really an underlying condition that was going to have a cascading effect on all
Sure.
those other health conditions.
Absolutely. Let's talk about some of the new interventions, weight loss interventions that you're using and seeing great success in your practice.
Well, I'm so excited right now. I feel
Yeah.
I wasn't practicing at the time, but I really feel like right now in obesity medicine, with all the new interventions, must have been what it was like for a psychiatrist practicing at the dawn of
Yeah.
Prozac, like in the late
Exactly.
80s
Yeah.
and the SSRIs.
Mhm.
There are some fantastic new and really game changing interventions.
Mhm.
Most people think of them, they'll hear about injectable. There are three currently on the market that are used. And these are really different from the old time appetite
Right.
suppressants, which would suppress the appetite. You'd lose weight
Mhm.
and then you'd stop them and you'd gain it all back.
Right.
And some of them even had abuse potential. So
Sure.
that would lead to some of the yo-yoing that people
Right.
talk about. And there are some good oral medicines, but I think a lot of people that I have come to my practice right now are talking about these injectables. There are some that are daily, and that's marketed as liraglutide
Mhm.
or Saxenda or Victoza. They have different names. It's very confusing.
Yes, it
I'll
is.
explain that just briefly. Is that if it's FDA approved for diabetes, it'll have one name, Victoza, Ozempic, Mounjaro.
Mhm.
If it's FDA approved that was for diabetes. If it's for weight loss or
Mhm.
obesity, then it will have a totally different name,
Right.
like Saxenda or Govi.
Right.
So
Yeah. And
people will
Wegovy and Ozempic are pretty much the same,
Same
correct?
thing.
Yeah,
But
same
you
thing.
remember back in the day,
Yeah.
remember for when Wellbutrin was FDA approved
Oh,
for
yeah.
smoking cessation and they
Exactly.
called it Zyban?
Yeah. Okay, a
Just a
little
little bit of a shell game.
switcheroo.
Yeah,
Yeah,
I'll say,
absolutely.
yeah. So, it's different. It's confusing to people.
Yeah,
And I
it
was telling
is.
you earlier, I had someone who just called and left a message.
Mhm.
And she says, "Hi, my name is Emily, let's
Yeah.
say." And she says, "My friend said I need to talk to you because I need to be on something." And she starts saying like, something that,
Yeah.
and
Yeah.
call me back.
Yeah.
And she didn't even leave her
That
last
is
name.
great. That's
So
great.
it has entered the
Yeah.
popular culture, sometimes in
Yeah.
a negative way, though.
Right.
I had a woman in her 50s. This is someone I know, very educated, smart. She says, I want to talk to you about this new medicine. And she said, it's approved for weight loss. And I said, no. I said, that one was approved this summer, but it's
Right.
for diabetes. She said, no, no, it's for weight loss. Because on my TikTok, I saw a video about it.
Oh, and TikTok is absolutely, Dr. Google.
Yeah, and I said
Yeah.
I've been
Yeah.
Google Doc before. I never TikTok Doc
Yeah,
before. So
right. Yeah.
so people are hearing about it, but some of
Yeah.
them might not fall into a category or might have health complications, like you
Right.
said with gastric surgery.
Sure.
You need to talk to your doctor before just going on those. So I'm
Absolutely.
glad that you brought that up.
Yeah. So let's talk a little bit about Hollywood, right?
Yeah,
Every day when you look at your Apple News on your iPhone, or you look at really any newspaper or online newspaper, you're seeing articles about this miracle. And again, they're calling it weight loss drug,
right.
right? That's FDA approved for diabetes, but people are using it for weight loss. Let's talk a little bit about Ozempic because, at J Flowers, we see a lot of patients from Los Angeles, the
Yeah,
LA area, and every one of them ask about Ozempic, it
yeah.
seems like. So talk about Ozempic for just a minute and the proper use of Ozempic.
So Ozempic is the brand name. It's
Mhm.
semaglutide, and then it's also FDA approved for obesity under the name Wegovy.
Right.
But most people are seeming to attach to the Ozempic,
Yeah.
and it's heavily marketed.
Yeah.
And then there's an oral pill of it, Rybelsus. So this is even more confusing. But let's just leave it
Yeah.
out of there. But basically, this medicine is a weekly injectable
Mhm.
medicine. It is not like an injection into your muscle.
Mhm.
It's a rather painless injection into maybe abdomen, basically subcutaneous fat.
Right.
So you barely feel it. Very, very tiny. And this medicine is really a game changer because it's a metabolic medicine. It's a GLP-1 agonist. We're not
Mhm.
going to go into all the
Right.
biochemistry,
Yeah.
but basically it radically slows down
Mhm.
gastric emptying.
Okay.
And what that means when you have a meal, you will get fuller faster and it will slow down your GI tract so that, you know, uh, the old fast food,
Mhm.
you won't get a few bites of that burger
Right.
or those
Yeah.
chicken, strips before you're going to
Exactly.
feel really full. And we talked interestingly, I even have some patients because I know your deep
Mhm.
background in addiction medicine that some people say some certain foods taste different. Alcohol tastes differently for some.
Yes.
And I don't know how to
Right.
fully put that in, but I've had some people that just will not drink and some
Mhm.
sugary snacks don't
Mhm.
taste the same. But
Yep.
it really can allow people to lose. The studies show at least 50% of your total body mass. So think about that. So we talked about that
Amazing.
person who's
Yeah.
240 pounds. Then you could start talking about a 30, 35, reasonably expect a
That's
30
right.
to 35-pound. And that starts saying, okay, wait, I could get to 200. I could get out of the
Mhm.
2X size.
Right.
I could get back into shopping at a regular place.
Right.
That's really powerful for
Mhm.
them. And that's really different from when you say the diet and exercise of
Yeah.
losing 5% of your total weight.
That's a huge difference.
It is
Yeah.
huge.
I was talking to a patient the other day who has been on, I can't remember if it was Wegovy or Ozempic, but nonetheless, the patient had been taking it for about 6 or 8 weeks at that point. And she was saying that prior to starting it, she was what I think is referred to as grazing, right? A
Mm,
grazer. So she would walk by the kitchen, and if there was a jar of M&Ms on the counter, she'd stop and grab 3 M&Ms
yeah.
and snack on them, or she'd go through the kitchen, and if there was a candy bar at the office or somewhere here, and she tended to order dessert after meals, right?
Mm,
After dinner when they went out to dinner. And she said, and she was not an alcoholic, didn't have a history of alcoholism. No one in our family had a history of alcoholism. And so she was a social, occasional drinker. And she said, it's so interesting. My grazing has completely stopped. I walk through the kitchen and I look over and look at some M&Ms and I just turn away and keep walking. She said, I don't even think about it anymore. She said, but one of the interesting things that happened to her is she said it also, she said, I may have gone out on a Friday night with friends or neighbors and had 3 or 4 glasses of
mm,
wine. She goes, it's so wild. I can have 1 or 2 glasses of wine. And then I just say, you know what? I'm good for the evening. And
yeah.
so, not being an alcoholic but cutting down the number of drinks, right, from 4 to 2
Makes a big
is a
health
healthy
difference.
thing. Yeah.
Makes a big health difference. But I've had some people, it really brings up sometimes people's attitudes because I've had
Yeah.
some emergency phone calls
Yeah.
after people started these medicines, especially the ones that really lead to some
Mhm.
substantial weight, and said, it's 11 o'clock and I haven't had breakfast. And I said, okay. And they'll say, well, breakfast is the most important meal of the
Mhm.
day. And I said, well, who told you that? I mean,
Right.
so that's one,
Yeah.
ancient Romans didn't even have breakfast. They didn't have a word
Exactly.
for it.
Right.
Some will call me and say, urgently, I'm really upset.
Mhm.
I didn't clean my plate. I have food left over my plate. What do I
Mhm.
do about this? Since I started the medicine, I can't clean my plate.
Mhm.
I said, well, okay, that's a good thing. No, my mother or my grandmother said, you always
Oh,
have to clean your plate.
yeah.
So that people might eat 2 times a day, that they
Mhm.
might not graze, that they might
Yeah.
have smaller meals, I think is really helpful. It sounds a lot like the intermittent fasting
It
that's also
does.
so
Yeah.
popular these days,
Right.
but also not having that sweet tooth or alcohol
Yeah.
calories. So that's probably good for someone's weight loss.
Absolutely. I remember many, many years ago, John Travolta told Oprah, they were talking about weight
Yeah.
loss, and he said, everything on my plate, because the way I've lost my weight is everything on my plate. I fill my plate the way I always have, and then I eat exactly 50% of it. And it seems like with Ozempic or Wegovy or
Yeah.
these other medications that you're prescribing for a healthier lifestyle, that we're seeing that people eat about 50% of it, 50,
Yeah.
60%, but not the whole plate. And they're not fatigued. They're not tired. They have more energy.
Yeah.
They've even, not that it's a motivator, but psychologically, it's a motivator to get up and go to the gym.
Well, you have said that, but I think if you really look at the field,
Mhm.
it was always focusing on diet and exercise. So the
Yes.
over that's why I think it's been a sea change in the whole field and why I'm interested in it now.
Yeah.
Because the field was always
R-
looking at diet and
Yes.
exercise. And regardless of that, and really, I think making people feel bad about their lifestyle choices,
Mhm.
like it was a moral failing.
Yes.
And what I'm
Yeah.
seeing is the exact opposite. I see people who go on the medicine who don't do anything with diet and
Right.
exercise,
Yep.
and then they lose the first 5 or 10
Yeah.
pounds, and they start to make a change, and they say, I got my husband to drag the thing from the garage, either the Stairmaster or
Yep.
the Peloton or the bike
Oh, yeah.
and they drag the treadmill into their bedroom,
Yeah.
and then they start eating, I'm gonna cut the
Mhm.
fast food down,
Yep.
cut it to maybe once a week, once or twice instead
Right.
of 3, 4 times a week, and they start making it's almost like it gets them started,
Right.
as opposed to the traditional, which is and you probably know this
Mhm.
in gastric bypass, I think the doctors say you need to lose this much before we'll consider you to be a
Yes.
surgical candidate.
That's
We
right.
want to see your buy-in, that you have
Mhm.
quote unquote skin in the game.
Right.
And I'm seeing the exact opposite. When people start to lose, it becomes a virtuous cycle. And of course, people say, hey, looking a little better. You're
Absolutely.
buying a smaller size. You
Yeah.
get to throw
Yep.
out some of those clothes or donate them.
Absolutely. And when we're not pushed to do something or we're told, if you don't go exercise, pretty much you're a loser, right? And what this is doing is psychologically motivating us to get out, feel better, exercise because we're getting positive feedback
Yeah.
anyway, instead of that negative feedback. Let's talk about BMI.
Yeah.
First of all, tell our audience, what is BMI?
Yeah.
And for an average or typical, however you want to describe it, male, female, what's a healthy BMI?
Sure. So BMI is controversial and much maligned, but it's still what
Mhm.
defines overweight or obesity.
Sure.
Specifically, a BMI of 25 or above is clinically overweight. That's 25 to 29.9. Above 30 is obese. So when I use
Right.
these terms, that's that. And you can calculate these things. There's online, just Google BMI calculator, but if you want to be mathematical, it is your weight in kilograms.
Mhm.
So the pounds divided by 2.2, that's your kilograms.
Yep.
And that is divided by your height in meters. Again, we don't use the metric
Right.
system,
Yep.
squared.
Okay.
So now BMI does not apply to some of the people you and I see.
Right.
Any elite athlete will come in, especially a running back, and will be clinically obese, even though their total body fat might be 6%.
Yes.
So these people, it's not going to apply to certain people.
Right.
And kids, we use growth charts.
Mhm.
And if you remember the pediatrician's office, they'll have different growth charts. And they're 95% of a percentile of weight is what's
Right.
considered obese versus 85% for overweight in kids. But bottom line, that's something you could look at today to see where you are. And some are going to be dismayed because some people I've had in my office, when I tell them, it's clinically obesity, this is a
Mhm.
medical condition, they'll say, well, no, I'm just curvy,
Right. Yeah. Yeah.
or
I'm big bone.
I'm big bone.
Yeah.
And I don't try to say it to reinforce stigma, but we
Mhm.
really need to understand that this is putting them at risk,
Right.
that this could take healthy life years off. This could raise your risk of cardiovascular disease. And a lot of times I'll ask about family history. And you can really get into if you've known someone who died from a stroke or had diabetes, and especially if they've had complications of diabetes, where they've had multiple amputations and
Mhm.
such a nasty illness,
Yeah.
how strongly linked they are to overweight or obesity.
Absolutely.
So that you really kind of raise their awareness. And for many of them, they haven't even had health care in many
Right.
years, including my doctor lawyer patients, Dr. Flowers. You know this.
Oh, yeah.
So then you do some labs or that, or
Yep.
you just check their blood pressure. And
Yep.
surprise, surprise, they have hypertension or high
Yep.
blood pressure. They have
Mhm.
diabetes. They have cholesterol problems. And that's when you start to say, this is an issue we need to address. And it is reversible. And you give them
Absolutely.
hope.
Yeah.
So that's
And that's the key indicator right there is, I think, giving people hope. When people feel hope, they're motivated, right? When they feel hopeless, they feel hopeless and they act hopeless,
we
right?
get a whole lot of
Yeah.
childhood stories. I've had
You sure
some,
do.
people tell me that their parents put them on a quote unquote fat farm, and you
Yeah.
hear, or they were teased relentlessly, or they had
Yeah.
nicknames. I ask about
Mhm.
that now in my evaluation because it
Yep.
brings up a lot of the childhood trauma
Right.
that comes with it
Yeah.
that also prevents people from taking appropriate action.
Absolutely.
And just telling them, no, that was you at 10 or
Mhm.
14 or 18.
Mhm.
This is you now, and this could be the new you.
That's
It's very
right.
empowering. I think that's where so
Yep.
much of the interest is. However, we talked about the Hollywood. It's not there for the 5 or
No.
10 pounds before the holidays, which I
Right.
got some of those calls
That's
too.
right. Yeah. I
It's
bet.
really meant for
Yeah.
the best response are those people who really clinically meet
Right.
criteria for that.
And is there an age criteria in your mind for using weight loss management in your clinic?
Increasingly, no.
Mhm.
In
Yeah.
fact, some of my best results are in
Mhm.
my teenagers
Mhm.
because the biggest rise in obesity across our country right
Yeah.
now is in youth.
Yeah.
And we talked about some of the factors. And yes, but they are also highly motivated. They're some
Yeah.
of my most motivated. A lot of them have not been taught how to eat. And I know you do that here at J
Right.
Flowers very
Yeah.
well, but a lot of people don't know. So you tell them, where you talk to them, you give them, my teenagers are really inclined, but
Right.
they also seem to respond very well to these interventions.
Sure.
And increasingly that I'm offering to them. Whereas in the beginning, I
Yeah.
was just focusing on those people I've treated for years, usually adults in their 30s, 40s, or
Right.
50s, that have already started to have complications. I think it's probably why I'm in child psychiatry, is to catch people earlier
Right.
before really all the problems, secondary issues that develop with mental illness, most of which develop before the age of 18.
Right.
In fact, half develop before the age of 14. It's the same thing with obesity. Before people have high blood pressure,
Right.
diabetes, joint problems, get them early so they can
Absolutely.
lead a healthier life.
I agree. What about male versus female? Are you seeing a difference in the percentage of males versus females that come in? I would think in my own mind, it's probably more females, but I'm hoping that you're going to tell me, no way, those days are gone and it's equal male female.
In my practice, no, but
Yeah.
I have a
Yeah.
couple of patients that
Yeah.
happen to be female that are wonderful apostles and tell
Yeah.
all their friends. And I think there's a little bit more
Yeah.
of like, how did you do that?
Yeah.
You've lost a lot of weight.
Right.
And once you tell them it's not surgery, because no one wants to do
Right.
surgery,
Yeah.
then they start. So I
Yeah.
think it is. I hope it is, because
Yeah.
many men in this country are silently suffering from that. Men already live a much shorter lifespan than women in our country, and diabetes,
Yeah.
heart
Heart
disease,
attacks, heart
and
disease.
obesity. All
Yeah.
of those things, many of them stem from
Right.
obesity and overweight. That is one way. So I hope men listening will take it in themselves. And if it's for cosmetic, that's fine. But
Right.
it's, if
Yeah.
they think it is, but it really is for their health.
Absolutely. It's
Yeah.
for long-term longevity and health, right?
Yeah.
Well, Dr. Stevens, unfortunately, we're just about out of time. What do you want to leave the audience with in talking about a healthy weight, a healthy lifestyle? And I also want to know, how does everyone reach out to your office and get an appointment? Because I know everyone's going to want to do this.
Well,
that wants to be healthy, that needs to be healthy.
Well, you can
Yeah.
look at my website's Jon Stevens, Stevens, MD.com.
Yep.
They could go on there, find my information, see if this is right for them,
You bet.
book an appointment. I want people anyone listening can make a healthy lifestyle change today.
Yeah.
Limiting those high sugar, high fat foods. Read some labels. If you don't know what those ingredients are, it's probably a processed food.
That's right.
So cook at
Yeah.
home more.
Mhm.
Cook with family. Get your kids cooking with you,
Mhm.
because you're teaching them how to eat. Portion control.
Yeah.
I guess the John Travolta.
Yeah.
You don't, or maybe get smaller plates.
Right. Exactly.
In your house, maybe
Yeah.
not big plates,
That's right.
but also trying to target 150 minutes per week of exercise. Try to prevent yourself from getting to that place in
Right.
overweight or obesity. But
Right.
if you're already there, seek help, talk to your doctors, reach out to people like me, J Flowers Health Institute. You have a
Right.
whole team here. I'm just,
Absolutely.
I'm just in my office. So reach out to teams. And then if you've had a positive journey, tell
Yeah.
people about
Yeah.
it, share it. Because a lot of
Yeah.
people still have not heard about it, or hearing, or have preconceived
Absolutely.
notions like it's
Yeah.
a personal failing, like
That's
a character,
right.
and it's not.
Speaking of that, what I want to say real quick, and I'll wrap up with this as well, is patients whom have long-term depression and obesity, what we're seeing is when they're coming to see you is we're not only seeing a decrease in their weight over time, we're also seeing a significant decrease in their depression, right?
Yeah.
When we feel better or we look better, we feel better, right?
Yeah.
When we're satisfied with our bodies and we're out doing things that we stopped doing because we didn't feel good,
Yeah.
and we're exercising a little bit more, and we're not grazing in the kitchen, and we're not getting up in the middle of the night to go grab some or ice cream out of the freezer,
Yeah.
like maybe people used to, they intrinsically feel psychologically better. So we've seen amazing results here at J Flowers long term for patients that really need this. Again, I'm with you. I know it's very popular in Hollywood and LA, and some people are utilizing it that may not be obese.
Right.
What we want to stress is this really is for obesity. Talk to your doctor about it, but most importantly, call Dr. Stevens because he's board certified in this, and you need to see an expert. So, Dr. Stevens, thank you very much.
Thank you so
Yeah,
much.
you bet.
Take care.
Absolutely. Reach out to jflowershealth.com or 713-783-6655. Thank you, everybody, for tuning in today. And you can find us on iTunes, Spotify, and pretty much any other place that you can listen to a podcast. Thanks, Dr. Stevens.
Thank you.